Okay, thank you for joining us on this episode of the Kat and Coca Report. We're delighted to have as our guest today Dr. Aaron Cariati, who's Associate Clinical Professor of Psychiatry at the University of California, Irvine, where he is also Director of the Bioethics Program. Dr. Cariati is the chair of his hospital's ethics committee and is presently working on a task force with the University of California Office of the President to prepare for the possibility that a surge in demand for intensive care due to the coronavirus pandemic will outstrip the supply of equipment and staff. He is the author of numerous articles in peer-reviewed journals and in the lay press, many of which are focused on end-of-life issues. Aaron, welcome to the show.
Thank you. It's good to be with you both.
Aaron, before you tell us about what you're doing specifically related to this pandemic, can you orient us a little bit about your role as a bioethicist day to day, and how you got selected to deal with this particular problem?
Sure. So at my own institution, which is UC Irvine School of Medicine and UCI Hospital, I am the director of the medical ethics program in the hospital and in the School of Medicine. So I teach the required ethics course for the first and second year medical students, and I chair the ethics committee and the clinical ethics consultation service. So that's the folks in the hospital that are called upon when there's a difficult dilemma to resolve, or when there are difficult ethical or legal issues that the treatment team is trying to navigate on a particular case. And in that capacity, we deal with a lot of end-of-life cases, among others, difficult decisions at the end of life. And so as the coronavirus was clearly getting worse around the world, and we started receiving reports from Italy and elsewhere that not only was there a huge influx of cases at some hospitals, starting probably especially in northern Italy, the Lombardy region, but that the influx was so severe and so rapid that the demand for ICU level care and for things like ventilators, which many of the coronavirus patients require, as we probably have heard, the demand was far outstripping the supply. And so we saw reports on the ground that doctors there were starting to have to ration their use of ventilators and triage, which is a word that's usually associated with a military battlefield kind of a situation, a disaster situation in which you have a mass casualty event, a bomb goes off, or there's an earthquake, or in this case, a pandemic, where there are so many patients all at once that the ordinary local healthcare system that would care for burn patients or infected patients in the case of a pandemic simply doesn't have the resources to deal with that number of patients coming in all at once. And as I said, at least in recent times, the context in which we've seen this play out most frequently would be a wartime medic having to decide which injured soldiers are the ones who are both in need of care, but also most likely to survive, and starting with efforts to save those before using limited or critical resources on other individuals who have a lower probability of survival. So this is a very different, obviously, this is a very different way of thinking about deploying medical resources. It's one that no one really wants to think about, but we thought it was best to start preparing here at UCI. So I got a team of ethicists and critical care docs and anesthesiologists and nurses and other sort of key stakeholders and people with expertise together to start studying how would we handle a situation in which a sort of worst case scenario situation in which we exceeded our surge capacity. And from there, we got tapped a few weeks later by the UC Office of the President. We were sort of aware that there were things happening at that level on this issue as well. But several of us were invited on board that task force, that work group, to try to puzzle through a policy for all of the UC, all of the University of California hospitals.
Okay, so that would be sort of statewide.
That's right.
Yeah. Um, well, how does even one start? Do you dust
Right.
off Childress and Beauchamp, the textbook of bioethics, the classic, to see what do they have a chapter on this, or is it completely, or do you go to the military archives and?
Yeah. No, it's a great question, and the sort of traditional principles of clinical ethics have to get stretched pretty far to fit a situation like this, because under ordinary circumstances, obviously, we want to give every patient the very highest level, or the most optimum level of medical care that is available. And in a country like ours that is resource rich, um, fortunately, most individuals have access to at least some basic level of care. We know that there are uninsured and underinsured folks, but they can at least get access to care through the emergency room and county hospital system. And and so doctors at the bedside don't have to worry about issues related to resource allocation, and they can do their very best to benefit and to minimize harm and to treat fairly and justly and to respect the autonomy of each individual patient, right,
Right.
one at a time. And so
Right.
those
So
traditional
correct.
Beauchamp and Childress principles of biomedical ethics are easy to apply. But then what's happening in the pandemic situation is that we're shifting from that clinical ethics model to what you might call a public health ethics model, which is foreign to a lot of clinicians, which involves other principles having to do with the just allocation of resources, having to do with transparency with the public and fairness in the process, and to sort of boil it down to the simplest level, in a crisis situation in which your demand far outstrips your supply of something like, we'll take ventilators as this sort of paradigmatic example, but it could also apply to medications and other resources that might become scarce. The key ethical principle that most ethicists can agree upon in these scenarios basically boils down to save as many lives as you can. Okay, so we have to, which on the face of it sounds sensible and sounds good, but the corollary of that and what that means on the ground, and the reason this becomes so difficult for individual clinicians or even hospitals to think about, is saving as many lives as possible under those circumstances could involve something like, yesterday Mr. Jones came in and was placed on a ventilator and he's in our ICU now. Today, Mrs. Smith is in the ER requiring emergent ventilation. And when we assess Mrs. Smith, we see that her prognosis, her chance of recovering from COVID-19 is better than Jones, because she doesn't have his co-occurring diabetes and hypertension and cardiac disease, and she's younger and she has fewer risk factors for mortality or a poor outcome with this disease. In ordinary circumstances, we would give them both a ventilator, but if we just ran out of ventilators, we just gave the last ventilator to Jones, then that principle of save the most lives as possible with the resources that you have could mean taking Jones off the ventilator and providing him comfort care or palliative care only, or at least a level of care that's lower than what he was getting when he was on the ventilator. Maybe there's something we can patch together for him with high flow oxygen or whatever to try to give him something that's better than just transitioning to comfort care. But in any case, he's getting less than he otherwise would have gotten, because we're going to take that ventilator and now give it to Mrs. Smith in the ER, with the idea that if we do this in the aggregate, where we prioritize individuals who are sick enough that they need that resource, but have a better chance of recovering with that resource. If we do that on a mass scale in the aggregate, we're going to save more lives. But of course, what that means for Mr. Jones is that he may be deprived of something that under ordinary non-pandemic, non-crisis circumstances, he would have gotten, right? And so making a decision like that is obviously a very serious matter. It's not what most of us are trained to do. Most of us are trained to withdraw or to discontinue or transition to comfort care if we know that this ventilator is not going to help Mr. Jones, right? The whole concept of non-beneficial or futile care, right? If we know that he's not going to survive this hospitalization, we explain that to his family or his surrogate decision maker, and they agree, yeah, he wouldn't have wanted the dying process to be prolonged indefinitely or unnecessarily. We think it's appropriate to transition him to comfort care only. We're used to doing that kind of thing in the ICU, right? But that's not quite what we're talking about here. We're not talking about taking the ventilator away from Jones because there's no chance anymore that it's actually going to help him or benefit him. We're talking about taking it away simply because there's a less of a chance that he's going to benefit than that someone else might benefit.
Mm-hmm. Is this so? Presuming that saving more lives is better, it's better, obviously numerically for the lives that are saved. But it's better also for society, or
Well,
how does that right?
That's a hard question, and it's not entirely a clinical question.
Mm-hmm.
Saving the most lives, if you accept that as a basic ethical principle, and whether or not you accept that, I think, is also a philosophical question. But assuming that we accept that as our fundamental ethical principle here, then the question of how to do that becomes a kind of empirical clinical question. It's not an easy question. And in fact, the triage protocols that we have are based more on plausibility than they are on actual data. We don't have a lot of data on these kinds of triage tools being deployed in real-time circumstances. So one of the things that we're wanting to do, if it gets to the point where there's certain places in the country that have to do this, and it's looking like that might happen in New York, it's looking like it could happen elsewhere. But if that's happening, then we need to study how it's going. We need to, in real time, prospectively research, are these places that are using a particular type of triage algorithm actually getting better mortality numbers than other places around the world or around the country that might be using a first come, first serve or another method for selecting who gets what. Right now, we don't have that. So the best that we can do is try to construct a triage algorithm based on clinical data that we have on ICU mortality, and hope that, if it's based on reasonable evidence, that in the end it's actually going to accomplish that. But as you just sort of mentioned, there's another question about whether or not deploying something like that is good for society, and what kind of side effects might doing something like this have. And I think there's very serious considerations and sobering considerations that we have to think about. And I'll preface my remarks on this by saying, right now and for the rest of the show, I'm going to be giving my own personal opinions on some of these difficult ethical questions. I'm not representing UC Irvine. I'm not representing the UC Office of the President or the opinions of our work group. That's still a work in progress. We haven't published our guidelines yet. I'm happy to comment on the guidelines once they are published. But for now, the rest of the show, this is just Dr. Cariotti.
Fair enough, sure.
Speaking, which is one opinion in that mix. Okay. But some of the things we want to think about, one of the questions, for example, is supposing that you put people into different triage categories based upon their prognosis. Within a category, how do you deal with a tiebreaker problem, right? So we got 9 people in category 1 and 4 ventilators to distribute among them. And supposedly all of them got the same score from the triage tool on probability of survival. And so how do we decide between them? Well, some people have suggested that critical workers should get a nudge. And critical workers could be something like ICU physicians who are necessary to treat people during the pandemic. Or critical workers could be police or firefighters or other people who are important for the general infrastructure of society. There's a couple of different arguments that have been deployed in regards to whether or not critical workers should be prioritized, at least as a tiebreaker within categories. Well, ICU physicians are putting themselves in harm's way. They're at higher likelihood of contracting this virus because they're treating patients. And especially under conditions like we have now, where there may be inadequate personal protective equipment for them, shouldn't there be some sort of reciprocity in this process? Shouldn't they get a nudge on triage priority if they get sick and require a ventilator?
So that would be an argument not necessarily for the common good, meaning because they're going to be more productive in the physical, but a moral argument of, as you said, reciprocity, or that they are due for the things that they've done in the past.
That's
they
right.
are due a sort
That's
of
right.
an extra privilege, or.
Now, I have to admit that as a physician, I'm sympathetic to that argument, but ultimately, I don't, at the end of the day, find it fully convincing, and for a couple of reasons. One is that I'm aware of my own bias, that it can seem a little self-serving, especially if there are physicians involved in designing these triage tools. It can seem a little self-serving that physicians would give themselves priority or give themselves a nudge, right?
Right. And
the other issue here is, well, isn't this what you signed up for, right? Firefighters run into burning buildings where other people are running in the opposite direction. Isn't it the case that you agreed when you entered this profession to put yourself at risk in a situation like this in treating the sick? There are some associated risks of contracting infections in a pandemic, for example. Why should you be rewarded for something that is simply a part of your job?
Yeah, sure.
Now, I'll enter a small caveat there and just mention, as it relates to the COVID pandemic, that it's true that physicians did sign up for this, just like firefighters signed up to run into burning buildings. But firefighters also didn't sign up to run into burning buildings with their boxer shorts on. And so physicians have not signed up to run into these situations without adequate personal protective equipment. So I think that is a social issue that we need to address very, very, very urgently. But set that aside for now. The other reason that I don't ultimately find the reciprocity argument convincing is more or less what you just mentioned, that if our central ethical principle is the common good, saving as many lives as possible, the reciprocity argument doesn't do that. I think if you're going to prioritize healthcare workers or other critical workers, the only argument that you can rest that upon is what you might call the multiplier effect. And that's the idea that if we save these critical workers, in the end, we're going to save more people. Or the flip side of that, if we don't save these critical workers, in the end, more lives are going to be lost. So that argument might run as follows for the ICU physician, and it has a couple of assumptions embedded in it. Assuming that the ICU physician recovers on time to get back into the fray and contribute to the care of patients during this pandemic, and assuming that it's going to be difficult to replace this ICU physician, so they're necessary for that war effort, you might say, then I think the multiplier effect has some plausibility. Again, this has not been proven by empirical evidence, but I think it has sufficient plausibility that it's reasonable to prioritize healthcare workers under certain conditions. If we have reason to believe that they could recover on time to contribute, and if we have reason to believe that if we don't, as a general policy, try to save physicians on the front lines, we may run into critical shortages, right? You can replace one ICU physician. You can pull someone up from the neonatal ICU and tune up their skills and teach them, how to transfer their skills in treating babies on a ventilator to treating adults on a ventilator. That's probably feasible. But if you lose too many people, you can't abandon the premature infants in the ICU. At a certain point, someone who takes 8 postgraduate years to train is going to become very difficult to replace.
So Aaron, are you here in these considerations? Would those be made sort of um, ahead of time, where you would, you would list out healthcare workers or ICU physicians or whatnot, or would it be done, on on an ad hoc basis?
Yeah,
Because
that's a
if
great.
you right, if you say healthcare physician or ICU physicians, maybe the patient was an ICU physician, maybe he was actually happened to take his vacations for the last 4 weeks and was not particularly contributing or whatnot. Or you could have somebody, uh, let's say you have a hospital administrator, and I don't have any love for hospital administrators, but it so happens that in your particular hospital, that person is
Yeah,
extremely critical to the operation of the hospital, and
right.
right, and so you could have a lot of people that are all of a sudden you realize how essential they are, when in fact when you're drawing your little list, it's not
Yeah,
apparent, right?
yeah, that's right. So ideally, we would have all of this sketched out in advance. So what you don't want to be doing in a crisis situation is doing things ad hoc, flying by the seat of your pants, and making things up as you go along. So preparation is important, we're not. I should say too, we're not entirely reinventing the wheel here. So there are some resources at the federal level and at state-specific levels that are helpful here that have already been developed. So the Institute of Medicine in 2009 published a letter report and then a follow-up longer report in 2012 with some guiding principles for this kind of work. The VA published some guiding principles for their hospitals, as well as actually they've published a specific triage tool that you can take a look at and critique. And then following the IOM report, several states took up their recommendation to develop state-specific reports. My own state of California, unfortunately, was not one of those that did this work, but we can look to New York and Maryland and Michigan and Wisconsin, which were states that not only gathered experts in critical care and bioethics, but also several of them did the really important work of engaging the public and getting public feedback from the people who would be impacted by these kinds of triage decisions and feeding that back into the process of developing triage tools. So there are some triage tools out there that can be tuned up, so to speak, for the current pandemic. And most of them advise having something with these categories clearly spelled out. And it is very hard to draw the right kind of line around critical workers. Some of the states gave up on that project because
Mm-hmm.
they couldn't agree on who was critical, or the category became so expansive that there were too many people in it. It didn't
Right.
make sense to nudge them anymore. So that is a really hard problem. We haven't finished working through that problem yet at the UC office at the present. We haven't decided exactly what that's going to look like in the final report yet, because it's a very, very difficult one to try to finesse.
Yeah, okay, because I mean, isn't it maybe the premise that what you just said, that we don't want to do some things ad hoc? Maybe actually there's no other way except doing it ad hoc. Maybe at the end of the day, you make the best decision that you can at in real time.
Well, I think what's going to happen is that we are going to have a template. We're going to have something prepared, and most hospitals should have something prepared. If not their own, then they rely on one of the already published protocols. Journal of American Medical Association, JAMA, just published an opinion piece, and in the appendix for that, they have the protocol from University of Pittsburgh. So the PIT protocol is out there already, and it's available for others to borrow, I think, if they wish. So you want to have something and a plan in place, and people trained to use that triage tool ready to go. But at the same time, you want to be learning as you go. We want to be learning from this pandemic. How is it going to play out, and what's it going to look like? And is the real-time data that we're getting on outcomes actually changing our thinking on how we're triaging people? So I think you shouldn't start from zero. You shouldn't start from scratch and sort of try to wing it, because what we know about these surges is that they hit very quickly. You're fine
Right.
until you turn the corner on that exponential curve, and then you're not okay. You wake up one day and you're slammed. So you don't want to be caught off guard, but at the same time, you don't want to devise something that's so rigid that it can't be responsive to ongoing feedback. So I think it's going to be a kind of dialectic between those two things of having something in
right.
place, but improving it and 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 feeding back into it information as you go.
And the feedback, is it going to be mainly sort of the number of lives? I mean, it's sort of a, because here also we when you talk about, as a general principle, there should be, the number of lives saved. Um, let's imagine a scenario where, you could save more lives. I mean, I'm not saying it applies to COVID, but you could save more lives in the short term, but all the lives that you save are of, it so happens that it's of people who are going to die 5 years later anyways, or blah blah blah. Whereas you sacrifice one person here for the sake of 5 people, but that one person, if he had lived, he would live and be very.
So this gets to another extremely complicated and fraught area. Actually, this is an area where the published reports and the published bioethics literature on this has divergent opinions. The whole question of age criteria and long-term survival is a very complicated one. It's complicated ethically, and it's complicated legally, and it's complicated philosophically. So let me attempt to just quickly break it down. So some approaches say long-term prognostication is too difficult. Once you get beyond acute hospitalization and you try to prognosticate 6 months, 1 year, 5 years out, the further out you get into the future, the more muddy our ability to predict outcomes becomes. Given that we need something that can be deployed quickly, I mean, remember, we're talking about people in the emergency room that need to be very quickly assessed. Someone might be ventilating them, using a bag ventilator by hand while we're waiting to decide whether they get a mechanical ventilator or not. So, and there may be 10 more people in line behind them that need the same kind of assessment. So there have to be some, I hate using the word shortcuts, there has to be a reasonable assessment tool that can be deployed in that setting that has reasonable prognostication, and that the easiest way to do that, or the most feasible way to do that, is to ask the question, can they survive the thing for which this ventilator is being given? Can they survive this acute hospitalization? And only looking at that comes with the kinds of complications that you just mentioned, right? Are we saving cancer patients that would be dead in a year anyway of another illness? But because long-term prognostication is so difficult, also because there's worries about potential discrimination issues, potential disability discrimination issues, potential age discrimination issues. Some of the published literature and some of the state reports have stuck to the safest criteria, which is acute stage prognosis, right? Now, age. Age is very complicated. One of the reasons it's complicated is that COVID itself seems to discriminate based upon age, right? So the early data out from China suggests 65 to 70-year-old, much higher probability of mortality. Above 70, even higher probability of mortality as compared to the general population. So age itself, at least above a certain age bracket with this particular illness, seems to be, if we believe that early data, I think it probably will pan out in this way, seems to be an independent prognostic risk factor, precisely the kind of thing that you want to take into account when you're thinking about a triage assessment, right? Even the short-term question of whether this person is going to survive the hospitalization, age itself might be independently predictive of that, aside from other comorbidities, at least for COVID. So, but what about comparing a 30-year-old to a 40-year-old who, when it comes to coronavirus, at least seem to have a similar prognosis, so far as we know, right? It's a very interesting philosophical question of whether a 30-year-old should be prioritized over a 40-year-old or a 50-year-old. Some people say, no, that's a form of age discrimination. Some legal experts think that that kind of nudging or that kind of prioritization may run afoul of federal anti-discrimination law. The HHS Office of Civil Rights just this week published an interesting bulletin that didn't answer that question, I would say, but sent a kind of warning shot across the bow that people devising these pandemic triage tools need to be very careful about the issue of age discrimination. And they didn't spell out what was and wasn't permissible there, but based upon some disability rights advocacy complaints against the state of Washington and the state of Alabama for some protocols that they are developing, the HHS Office of Civil Rights issued a brief statement suggesting that that this age criteria could be tricky, could be an issue. The arguments in favor are sometimes framed as what people call a kind of life cycle argument. And this is the philosophical notion that all other things being equal, people should have the right to proceed through the various stages of life, right? So someone who's proceeded through early adulthood, middle adulthood, later adulthood, and is approaching older age, maybe they should give way to a person in a younger generation who has not yet had the opportunity to live through those life stages. And I think there's something to be said for that argument. I personally, again, this is Dr. Cariotti personally, not any of the institutions that I'm working at. I can't say how the protocols that we're devising are going to ultimately come down on this issue. But my own view is I don't ultimately find the life cycle argument compelling. I think at the end of the day, death is the same for everyone. It robs everyone of everything. It's sort of the final form of loss. And in some sense, it's a great equalizer in that regard. So comparing the death of a 45-year-old to the death of a 25-year-old, I think is very different, very difficult, to say the least. The other thing that we want to avoid, which this has the danger of slipping into, I'm not saying it automatically does, but there's the danger of slipping into judgments about social value or the importance of someone for society. And that gets very tricky very quickly. I mean, are you going to value someone's contribution to society just because they're younger? What if the older person is raising a large family and has a lot of children depending on them? What if the younger person is doing very important scientific research? I mean, you can come up with 1,000 different what ifs about people's relative contribution to society, which complicate this to impossible proportions very, very quickly. So I think it's once you get away from very strict clinical prognostic criteria, you start treading on territory. Like maybe the multiplier effect argument for critical workers is still solidly grounded on saving the most lives. And once you move away from that, you start getting into judgments about the quality of someone's life or the importance of someone's life that has the potential to discriminate against people based upon their age or their stage of life or their degree of disability, and the degree to which they can or can't contribute to society. Are we going to deprioritize someone who's cognitively disabled but physically healthy simply because they're cognitively disabled and not making a contribution to the economy, for example? I would find a triage approach that involved those kinds of judgments to be very, very problematic. And so I think the life cycle argument is an interesting one, but ultimately I don't find it compelling. When it comes to age, I think we need to stick with age only insofar as it is prognostic and not think in terms of saving the most life years or, these kinds of metrics. I just think they're fraught with dangers. I mean, my own biased view, and I'll be the first to admit that this is a bias, would be, I would rather save a 30-year-old mother of two than a 25-year-old single person. But again, that's not something that I would put into any sort of triage criteria, because I recognize that to be a bias. It's based upon my own view about what that person is contributing to their family or to society or to whatever. And I don't think those kinds of judgments should be admissible in this sort of work.
Is drawing lots going to be part of the protocols that in the algorithm? At some point, there's a box and with an arrow that says
it very well might.
Flip the coin.
Which strikes people as a strange way to make medical decisions, right? So you start talking about a lottery or drawing lots. But again, the more you go through the kinds of exercises about, how do we decide who's contributing more or who's more important, or even who's more critical to control the pandemic, very, very, very hard questions. At a certain point, you reach the stage where you say, strange to say, and it doesn't on the face of it sound entirely fair, and it's not going to make anyone really, really happy, but maybe the best that we can do within a prognostic category, right? If all people have the same prognostic score, probably a lottery is the most unbiased way of deciding. Whether it's the most fair, it's at least not subject to the kind of biased judgments that other approaches might take. And so a lot of these already published protocols do recommend within the same prognostic category to go to a lottery to decide between individuals in that same category.
Okay. Well, Anish, do you have any, you've been quiet there.
No, I've been learning. It's been fascinating to hear how these things are doing. So thanks so much for kind of enlightening us.
I have I'll give you my thoughts. I'm not I don't have any institution to speak for, so I can only speak for myself. I'm speaking in the name of the Karan-Coca report. There's a lot of, there are inherent things, there are things that are making it inherently complicated. One difficulty is that we seem to vacillate between, I don't think we have a clear understanding of the common good. And frequently our notion of the common good is sort of an aggregate of the individual goods, right? And that's where we have this notion that if we save more, that it's better for the common good. But if you examine that, we have in the, already, that doesn't really hold much water.
Yeah.
And so there's something about the common good, but the common good, we don't have a good handle about it. And then our healthcare institutions are also, it's hard for them to know who they're representing, what community. Are we representing all? You have a hospital in Irvine. Are you representing the entire United States? Are you when you have a human being? Is it the common good of the humanity, or is it the community of Irvine, or the insurance contracts that you have, right? This pool of insured people that that's the common good, or so all these things are making this incredibly, as far as I'm concerned, probably impossible to solve or to gain clarity on.
No, I agree 100% that we don't have in American political thought and in our social ethics in the United States, we do not have a robust, well-articulated, well-thought-out understanding of the common good. The tradition of American individualism tilts away from that. And so if we even employ that term, we usually, as you suggested, think of it as the aggregate of each of our individual goods, which is not what we mean by the common good. We mean a shared good that all of us participate in that couldn't be produced by one or another of us alone working in isolation. And so it's not just a summative or an aggregate notion. It's something more than that, something beyond that. And in the absence of that, we tend to fall back on utilitarian criteria. I will say, in defense, however, of the approach that we're trying to take at the University of California it's save as most, I didn't actually articulate our central ethical principle fully, because it's save as many lives as you can with some important caveats and side constraints along the lines of, while at the same time respecting the inherent dignity of each human being and the equality, the moral equality of each human being. And so a purely sort of crass utilitarian calculus alone is not sufficient here, right? So let's assume, so what does that mean? Well, let's assume that we don't have enough ventilators for everyone who could potentially benefit from them. That doesn't mean that we just give them nothing, right? We have to both push for creative solutions to give them everything that we possibly can, and make sure they have adequate palliative, psychological, social, and spiritual care at the end of life. That is absolutely essential. Those things can never be abandoned, right? We also have to, on the back end, not just accept the status quo as acceptable. I mean, the whole notion that there's something more that we could be giving these people, if we could ramp up production in a sort of wartime production model, and we're not doing it. Well, those who are making these difficult triage decisions are also working in a team that on the back end has to be pushing against the supply chain and making it clear to the public that we're doing what we have to do right now. But this is an intolerable situation. It cannot continue for 60 seconds longer than absolutely necessary. And we need to be pushing on the back end to make sure that we get what we need to provide every single patient the best care possible. And a robust notion of the common good would induce us to do both of those things: manage the crisis as best we can with the resources that we have on hand, using the best clinical criteria that we can come up with, and trying to save the most lives as possible. I think is as reasonable a criteria as you can devise, without having a kind of God's eye view of the future and of all contingencies. We also have to coordinate regionally so that it's not every man and every hospital for itself, right? So the standards of care suggest that the same triage tool ought to be used regionally or even statewide, and perhaps even between states, that we shouldn't be doing something radically different at UCI than they're doing at the private hospital 20 miles away. That if we have spare ventilators, we're not hoarding them for patients that might show up tomorrow in our ER. We're taking transfers from the outside, even from outside of our own state or our own country if necessary. That a notion of the common good, I think, would, at least in a crisis, would get healthcare institutions out of their silo, out of sort of, well, we're okay. We're the University of California. We have a lot of resources. And I will say on our behalf, we have massively expanded our surge capacity. And the number of ventilators, and that, not at liberty to disclose all the numbers on that information, but I've been so impressed with what we've been able to do here. But there's community hospitals that don't have the same kinds of resources that the University of California or UCI has, that are not going to be able to expand in that way. And gee, if patients show up on their doorstep, we ought to be ready to help them and not just sort of take care of our own. So those who don't have access to care because of where they live or whatever, when it comes to especially when it comes to a crisis like this, I think it needs to be all hands on deck, and in a sense, a communal understanding of who that ventilator actually belongs to.
Right.
Should we offload New York a little bit and send patients to transport patients? Or?
I'm not opposed to that idea. I mean, that would take some careful planning from the epidemiological folks.
What about from an ethical standpoint? What about the risks of transmission in the community that you transfer these patients to?
Yeah, so tough questions. But if we're transferring the most critically ill patients, obviously those involved in the transport of the patient are going to be at some risk of transmission. But presumably, the patients that have been tested, that we know are positive, that are on a ventilator, if we transfer them to a hospital that has an available ICU bed, in a certain sense, the people around them are going to be pretty well protected. because the patient's going to be in a negative pressure room. They're going to have hopefully adequate PPE.
It seems like, and this is where, things get so difficult. It just seems like hospitals are important links in the chain of transmission. It's very, very hard. This is a hardy virus, and part of the reason it transmits so well is that it sticks around on clothing or whatnot. And so, anyone who, the folks that are taking care of them. So, for instance, you look at nursing homes are, of course, lower acuity settings. But if you look at a lot of places, especially places, I guess, that are getting overwhelmed, you really wonder whether or not hospitals are an accelerant in the community, because now you have a patient and that's in there, he has a high viral, he or she has a high viral load, is sharing a lot. It infects a younger caretaker. That younger caretaker may just have a little bit of a cough, doesn't even notice, and they're asymptomatic, and there's a lot of asymptomatic spread that happens after that. So I think it's been a challenge. I was asked that. I've been asked a couple of times by one of the ER folks in New York about, we're just getting overwhelmed and slammed. Like, we should start transferring these patients to different places. But I think, the best strategy is probably, because of this risk of transmission via healthcare workers, is to, build capacity there. So it's more about maybe, but then the next question comes in. All right, well, if you build capacity, we need ventilators for those beds. Does it make sense then to send ventilators from places where there's surplus to other places?
Yeah, so I think that is a prudential, pragmatic question that needs to be informed by good epidemiology. So where do we expect the brush fires and the flare-ups to explode next into a bonfire or something more serious than that? We don't want to pull ventilators out from someplace that's going to need them next week, right? And there's certainly the chance of making misjudgments in that regard, as we're learning about how this disease spreads and how the growth curves, tend to spike and so forth. So that's a hard question that is beyond my pay grade, because I'm not the guy who can look at the map and point a finger and tell you, this place is going to be the next New York. I just don't know. If there are people that can confidently do that and reasonably do that with a fair degree of certainty, then yeah, it may be that we need to redistribute some of these ventilators. I think best case scenario, figuring out how to do ICU beds in people's homes would be if we had all the time in the world to plan and to train people, that's what we would be doing, so that an emergency room doesn't become a kind of petri dish for COVID-19. That's going to be hard. It's going to be hard to get there during this pandemic, obviously. And even in the future, if you're doing that, can you really have one doc doing telemedicine ventilator control, from a distance, or bouncing from one house to the next? I mean, is that actually feasible? It's hard to say. I think now there are some things that we can do. One is remove all the non-COVID patients from the hospitals and put them in these on these hospital ships or makeshift hospitals, or find other places to care for them whenever possible, so that we can keep them away from the infected patients and focus on those who have the infection in the hospital. Obviously, keep patients that don't need to be hospitalized out of the emergency room and help them to manage the illness at home. There's a big push for that, so that they're not exposing people or getting exposed when they suspect but don't actually have the infection. So I mean, all of these are complicated questions, and we're learning as we go. It's a work in progress.
To come back to the go ahead, Anish.
One of the concerns I have is that there's such a when these systems, like New York is a perfect example, these systems start to get basically starting to get overwhelmed. You have there's a desire for more and more central control, because you want some central manager trying to help manage resources, for instance, right? One of the things I worry about is that allows scaling of error, meaning you're making a lot of decisions that in a fog of war and uncertainty. I mean, there's still so much debate about surgical masks and does everyone wear a surgical mask and they wear it the whole day? Does that make things better? Does it make things worse in the hospital? In what setting do you wear it? I mean, just little things like that. Right? But of course, the issue is that when you have one central person kind of establish policy for the entire hospital or for the entire health system, or in the case of Governor Cuomo, it seems like he's trying to establish policy for all hospitals in terms of what they can do, and he wants to have the ability to say, like, you have this much of a shortfall in terms of bed. We need to transfer these people from there to here, right? Or we need to move ventilators. So and people like that. They respond to that kind of, oh, there's somebody here who's managing this kind of situation, panic. So one of the things that it lends to this type of autocratic decision making that may actually make for large errors to happen, because there's so much what we know that's uncertain right now, So
Anish, it's interesting because I share your concern about this autocratic management on a large scale, but at the same time, I think it's inevitable that if we come back to the bedside, to the situations, within a hospital, with a team of doctors and taking care and having to make these triaging decisions. I don't know that it can be made in any other way than autocratically at the end of the day. Aaron, a couple of questions. One is, first of all, just to, I don't want to be sordid, but at the end of the day, this, the team will have the legal power to override the wishes of a family, for example, and say, against informed consent, we're going to, turn off the ventilator and do bag mask ventilation.
If we reach that crisis stage, patients and families will be informed as soon as they arrive, or if they are already here, that every ventilator trial is a time-limited trial, that we reassess every couple of days and reassign priority every couple of days. And that because of the circumstances, they may be assigned to a level of care that is based on the allocation of resources.
Right.
And one of the things that most of the protocols recommend is that you have a triage officer or a small triage team making those decisions, so that they don't have to be made by the bedside physician. But that triage team, or those triage officers, working in a team with someone at the hospital overseeing them, will have to be given that kind of authority and control. Now, the threshold of issue of when you reach that stage and when you get the green light for that may be made at a regional level, or that may be made at a state level by a public health official, right? Looking at the big picture question. So there's threshold questions of when have we reached that critical stage, and how do we know when we can no longer transfer people from hospital to hospital and still manage it. But once you reach that stage and that protocol is invoked, it does place a great deal of authority in the hands of the people at that hospital that are running the triage algorithm, sticking to those triage scores. Most places will have an appeals mechanism, but the appeal will not typically be allowed to challenge the algorithm itself, right? The appeal would be, well, we think you scored it incorrectly, or we think you missed some aspect of the patient's medical history that should have been included in the triage scoring. Okay, we recognize that we're not infallible here, but once it's invoked, the whole idea of on a case-by-case basis challenging the triage algorithm, if you allow that to go on, then you just have an ad hoc mess on your hands, and you risk, people giving favors to patients that they know or to family members, and all those sorts of things come into play. I want to comment too on Anish. I think your comments about scaling up errors if central command is taking control of everything I think it's an important consideration. There has to be, in a case like this, there has to be some sort of centralized control to establish sort of, you might say, solidarity, common good, needs big picture oversight. But the principle of subsidiarity, which is the notion that decisions should be made whenever possible at the level closest to those who are affected by them, that also needs to be respected in these circumstances. So maybe central control gives guidelines that have a little bit of wiggle room or a little ability for each hospital to adapt at the local level based on their particular circumstances. And the other thing that I worry about if there's too much centralized control over this process is right now we have thousands of different, I hate to call them this, small experiments running on how to manage this, right? And there's individual variation at various hospitals. There can be a downside to that, but there can be an upside to that too, and that people on the ground may come up with an ingenious, creative solution, or may try a novel treatment approach that actually works better than some other approach. And if we don't allow for doctors to use some degree of clinical judgment in treating these patients and devising treatment protocols, we're not going to innovate in this time of crisis. That's one issue I worry about. The other issue I worry about with too much centralized control is individuals at the local level offloading responsibility to take this thing in hand and do our best to fix it, right? If we're just passively waiting for directives to come down from above, that process might be a little slow because it's bureaucratic. It might not be immediately responsive to realities on the ground that may be changing hour to hour or day to day. And so allowing some room, at least in the treatment of this illness, for deft maneuvering on the ground, I think there's something to be said. There's something to be said for that, if only because we know so little and we have so little figured out in terms of managing this illness so far. We have some data, but it's still very early. So, you know, it'd be one thing if we knew exactly what to do with this illness. You know, we'd perfected the treatment protocol and everybody ought to be using it and the standard of care is clear. Then it's easier to get on board with centralized control of everything. But in a situation like this, I think you need some kind of balance of both of those things. And how you strike that balance that's a hard question.
Yeah, I think it's a very hard question. I personally, again, maybe to finish on my personal wishes, which I don't think will materialize, is that again. So as I said, we have a poor notion of the common good as far as I'm concerned, which you articulated very well. But nevertheless, in this particular situation with these epidemics, the unit of interest is really the local hospital. The local hospital, and I think it's fine that they should have teams that make those very difficult decisions. It should be left, probably not left to the individual doctor and so forth. They should be team, but they really, because at the end of the day, when the pandemic is gone, and so it's very unlikely that we're gonna have numbers to say, this is what we've learned, that we've said, we won't be able to tell. Okay? We won't have it's not a control experiment. So, but nevertheless, it doesn't mean that that certain hospitals will make wiser decisions than others, and the wisdom with which they practice, I mean, ideally, will be apparent to the people concerned, to the people of their communities. And so that's why I really think it should be left. There should be a lot of leeway. I mean, you want to have certain principles articulated and in guidelines and whatnot, but there should be leeway, and it should be left as local as possible, which, as far as I'm concerned, is really the hospital, to make those difficult decisions, to ask for help when they need to from neighboring hospitals and whatnot. But otherwise, if come crunch time, it's important to know which hospitals eventually come out of it, as far as their reputation goes, unscathed, or better, as opposed to the ones that were a little more careless and didn't know what to do and so forth. And that's how we learn, as opposed to pointing to the algorithm and say, hey, we followed the protocols and we all follow the same protocols, and it's a national guidelines throughout the states and so forth, which ultimately will be either utilitarian and mechanical and from my notion of justice, would be sort of a more unjust way of approaching this than if we let hospitals have the leeway, taking a chance that some will do worse than others. But that's
I have some sympathy for your argument. I really do. I think there's a lot to be said for what you're describing, and I think across the country, we are not going to have a uniform triage protocol.
Right.
Every
right.
state's going to differ, and
Right.
even within states, different institutions are going to differ. So we are going to have some of that, which I think is probably a good
Sure.
thing, especially since, as we talked about earlier in the show, some of the, when you get down into the weeds on, you know, how to run these things and how to prioritize within categories and so forth, it gets very complicated. And there's plenty of room for legitimate disagreement among people of goodwill on
Right.
those kinds of subtleties. So, you know, for that reason alone, there probably should be some variation. The one counter argument, though, that pushing in favor of standardization would be that there may be a danger of a small sort of star chamber of bioethicists, you know, the ethics committee at this local hospital, behind closed doors, developing their own plan for this and deploying it kind of on their own authority. I could see the public taking issue with, well, who gave you the authority to make these sorts of decisions, in a way that may not have been representative of the local community and may not have received feedback from the local community. Now, ideally, we would have done that work before the pandemic hit. And at least in California, we didn't do that work of soliciting feedback on a triage protocol from Californians. But some of that work was done in other states, as I mentioned earlier in the program. So at least using some of what those other states gathered from the public that these things are going to impact, assuming that folks in Michigan are going to, in some respects, be similar to folks in California, let's say. That might lend a triage protocol a little bit more plausibility and you know, especially if the protocol is based on something that was developed in a more public way. I think the whole question of by what authority you have done this is you at least have a partial answer to that question if you rely on, you know, Institute of Medicine was commissioned by the CDC, which is at least a quasi public entity. It's connected to the branch of the federal government, right? Likewise with the VA, right? It's not exactly a private hospital. It's not an elective representative of people
Right.
either. But
They're
it
not,
has,
and they're right.
you know, it has at least some tenuous connection to elective representatives. So these are hard questions in a pluralistic democracy about how, you know, what role does the ordinary person have in sort of having a say in these kinds of things, and then how do you even solicit those opinions and make sure that they're well informed and not just sort of
Right.
off the cuff responses.
Right. Well, you know, perhaps the last topic I want to touch on briefly is that, you know, certainly we hope it doesn't get to that point. I mean, we're gonna hope and pray that it doesn't. But if it did, you mentioned at the very beginning that we're not used to having scarce resources, which is kind of an illusion, because there's resources are getting allocated and rationed in ways that are sort of invisible.
This is true.
Have become very
This is a very
invisible,
good point.
and it's I think very important to realize that there are schemes, and they're not necessarily very just, of rationing, and it's inevitable that there will be rationing, and so it's a matter of coming to grips with that idea. I think the idea that healthcare is not, you know, cannot be rationed is false and dangerous. It's always rationed, and there are, you know, in my mind, better ways of rationing it. Again, with the principle that you mentioned of subsidiarity, leaving it as local as possible, because at the end of the day, health is really a particular good. I mean, it's my health, my body. It's not a common body. My own body is
Right.
not common, and so there are ways of allocating this, you know, healthcare resources that are more just than others. But we'll see. We'll see.
We will see. No, that's a good point. One of the things, I mean, maybe one of the things that comes out of, I think there's going to be all kinds of interesting social changes that come out of this crisis and these very difficult times. One of them may be a reassessment that whole question that you just described, and bringing some of those invisible decisions out into the
Right,
open, and drawing
right.
attention to the fact that, this is kind of already being done, not in the really dramatic, obvious way that pandemic allocation triage would require, but nonetheless, these decisions are being made in some ways behind closed doors, and
Hmm.
maybe it's time for better public deliberation on how that all works.
We'll see. Aaron, any final words before we close? Or
Yeah, so I mean, this is a very difficult topic to talk about. It's probably a difficult topic for listeners to consider. I don't want to give the impression to folks that we're on the verge of having to deploy these things. I can only
Mhm.
speak for my own institution and my own state. We're doing pretty well with surge capacity out here right now, and I want to reassure our listeners that hospitals are working around the clock to really massively expand their capacities. So hopefully it will not get to the point where we have to deploy any of these protocols or triage tools on the ground. But whether or not these are deployed on the ground, I think it's a useful exercise that many hospitals and healthcare institutions are having to go through now to think through these questions,
Right.
so that the next time we have something like this come up, hopefully we will be much better prepared and won't be caught so flat-footed. So I know there's a lot of anxiety out there about this illness, and I do want to reassure folks that that in the United States and my own state of California, I know elsewhere in the US, resources to treat this illness have massively expanded in the last few weeks. So we are doing everything we can, and I know there's many people in the public and private sector doing whatever they can to crank out more ventilators and get us what we need. And so I think we need to keep that in mind when we're talking about this.
Sounds good.
At the same time, we gotta hope for the best and plan for the worst, and that's what we're doing, thinking through these questions that we talked about today.
Aaron, where can people follow you?
At A Cariotti, Kheriaty, on Twitter, or aaroncariotti.com. There's articles and podcasts and other things that I've done on that website.
Thank you very much for joining us.
Likewise, appreciate it, guys. Enjoy the conversation.